Our next innovative pilot focuses on hyperacute workflows, specifically stroke. And joining me on stage is Dr. Gerrit Jan Noordergraaf from Elisabeth TweeSteden Hospital, who is a consult anesthesiologist and the chair of their residency program. Also, I might add, he was a colonel, in the Dutch Medical Corps. Also presenting on stage is biomedical engineer from Philips Research, Ana Leitão. The stage is yours.
Hi, thank you. Good morning. In this pilot, we address the stroke care workflow at the emergency department of ETZ in the Netherlands. The management of stroke is particularly time sensitive. This condition is characterized by the presence of a clot in the brain that blocks the flow of oxygen and can lead to serious damage. It has been shown that removing or dissolving this clot within the first 60 minutes of admission of the patient to the hospital, it can increase the quality of life of this patient. The current data sources in hospitals are enabled to provide minute-level accuracy and identify bottlenecks, so driving improvement is very challenging. Since every minute counts for stroke patients, we investigated if RTLS technology can help us address this problem. We started by looking at what the stroke pathway looks like at the ED. What are the protocol pathways? And confronted it with EMR data and RTLS. What are they telling us the pathway is? After this baseline, the hospital implemented a couple of interventions to improve the work of the professionals. Finally, we turned again at RTLS and EMR data to see the impact of these interventions. So I've mentioned RTLS a couple of times already. Let's see what that really means. RTLS is a real-time location system. It can have many shapes, but here's what the system we use looks like. We first install a network of radio hubs that will receive the location data and send it to our servers. Then we define the areas that we want to look at and install the beacons to define these areas. There are 3 types of tags that we use in this pilot. We have the staff tags that can be worn as badges. We have the asset tags that can be attached to mobile assets like the anesthesia cards. And then we have the patient tags. These can be placed in wristbands of the patients, and they will receive the infrared codes of the areas that are defined by the beacons and send it to the radio hubs. Here you can see what the RTLS areas look like. The beacons that we installed, if you look closely, they are the red dots and triangles in the images, and each of the areas is a colored area in the floor plan. We've defined 73 areas in the ED and radiology. We use more than 200 staff badges and 30 asset tags, and we used more than 100 patient tags by the end of the project that were used cyclically. Localization can be a very sensitive topic regarding privacy. So we've made a lot of efforts not only to comply to all the regulations, but also to make the staff members comfortable with this installation. We involved from the start the staff union and all the staff members. We provided multiple ways of communication about the technology and the project, including leaflets, Q&A sessions, and feedback sessions so that they know also what we're doing. When it comes to patients, we provided information about the project through information letters, and the staff also informed the patients and collected consent for the processing of their data. Let's see now what the stroke pathway at the ED of ETZ looks like. Most patients come through the ambulance bay, where they are received by the nurses and the stroke care team. Then the patient is taken to the trauma room where diagnosis will start. And there are 2 types of treatments that these patients can get. And that's thrombolysis, where the clot is dissolved with intravenous medication, and the thrombectomy, which is the removal of the clot. The thrombolysis can be done in the trauma room or in the observation room, while the thrombectomy has to be done in the radiology department in one of the angio suites. After receiving treatment, the patients can stay in the observation room or can be immediately taken to the stroke unit. To be able to follow the pathway of the stroke patients, the wristband with the localization sensor is given to the patient when they enter the trauma room and removed after discharge of the ED department. One of the particularities of RTLS is that it only provides location of the tags when the patients are within the colored area. The biggest limitation of the infrared-based system is that when tags are covered by thick fabrics, the signal cannot be seen by the tags. So there's no location transmitted. Part of the awareness that we must do during these projects is regarding these limitations so that we can increase adherence to the use of the tags and the proper use of the tags and maximize the quality of the data. Sorry for that. In order to facilitate the visualization of the RTLS and EMR data by the hospital after processing and analysis of the data by Philips, we've developed a dashboard that provides key information about the KPIs and detailed insights on each of the events of the pathway. You can see more details if you visit us during lunch in our booth.
Thank you, Ana. All right, let's go to look at some of the clinical aspects that we ran into. When we started the project, we knew that privacy was going to be an issue, and we were very happy to find that there was a lot of acceptance at the level of the board of directors and from the overall clinical staff. Okay? As we started, we also got all the stakeholders together at a team leaders level and took them with us in the development of our thinking. And we noticed that during the development of the project, more and more concerns became specific, and they addressed privacy issues primarily. And one of the things we were able to say was our project was about the technology. We weren't looking at the internal workings of the very well thought out stroke care pathway, but we were looking at whether the technology could give us information about that. We were looking whether we could create interventions and then monitor if the interventions were in fact helping the quality of care. Now, you all know that we had to deal with COVID, and I'm showing you a slide that just lets you see that every time, and that's the horizontal blue bars, that there was a new wave of COVID, the number of patients coming to the emergency department suspected of having a stroke decreased, while the number of people who actually were included as having a stroke didn't really change that much. So apparently the ED is a scary place to be if infection is a problem. So let's look at these timestamps, okay? And we've talked about that before in some of the other sessions. In the middle, you see the EMR data, the data in the electronic medical record. On the bottom of this slide, you'll see that the door to CT time in the square box is minus 15 minutes. So one of our patients, which was included in the study, actually had his CT 15 minutes before he arrived. And that's not possible. On the right-hand side, you see manual data points, and you see the CT scan. We went into the radiology program, and the CT scan has times embedded in it. That time is always true, and we use those to validate our data. And on the left-hand side, you see a column with RTLS data, and you see that the time to therapy became 30 minutes, which is very, very good, while the EMR time of 65 minutes in the middle certainly was not. So getting that data and getting it independently from the EMR, even if you integrate EMR data, is very valuable. So let's look at a number of specific points in our project. Okay, we wanted to implement the technology. We wanted to know whether we could actually see what we wanted to see. Okay? And as we went along, we noticed that there are things we need to address. We have outliers, people who enter the stroke pathway at an unusual point and create very long or very short time intervals. We need to be able to deal with them. We have people who have negative investigation times, like that example I just gave you. You need to be able to deal with those. Okay? You need to be able to know exactly when, and you heard that in Dr. van Wagner's talk, you need to know when the patient actually arrives at the emergency department. So we tuned our interventions around things that we wanted to measure. We added an RTLS badge at the ambulance bay so that the ambulance nurse could simply press the button, say, I have arrived. So we had a real-time zero. We labeled and bundled all sorts of materials that the nurses needed and put it in the next room so that they didn't have to go into the emergency room proper and potentially be distracted or asked questions while they were trying to get this workflow done. And it gave us the opportunity to add content into the RTLS measurement series. Okay? And we worked towards what sort of generalization can we do, because stroke workflow is very specific. It's a very short pathway. And we're working with the University of Maastricht on a PhD project and with the University of Radboud in what can you do with privacy aspects when it concerns RTLS. So back to our workflow in general, these are the interventions. A badge at the ambulance bay, getting that intravenous thrombectomy materials together and getting it into a box. And my own department, our anesthesia workstation, always in the angio suite, was typically turned off. And getting it up and running and doing the safety checks costs 11 to 15 minutes, okay? Real-time delay. And we brought an anesthesia cart and dedicated it to that location, saving time for the anesthesia nurse to actually get there and get to work. And this slide shows you in more detail what these interventions mean. So who do we see benefiting from our pilot? Because this was a question we wanted to address. Well, in 60 minutes of workflow, getting a real advantage is going to be hard. The number of people involved, the number of professionals is not going to change. The number of steps is not going to change. However, we know now, based on our own experimentation, that you can see that the benefit is in the lifelong health cost, because good outcomes have a tremendous impact. Saving a little bit on a catheter is almost irrelevant as far as that goes. And as Ana said, we invested in communication, getting good news back to the professionals involved in the process motivates them. A 46-year-old farmer who was in very bad condition when he arrived is now back on his farm doing his work and is very happy to be alive and as good as he was because his therapy was done on time. In summary, RTLS is like trauma care. You need a team, you need to communicate within the team, and it needs to be organized and thought through. Okay? Getting it right pays off, and RTLS gives you an insight which you might not otherwise have. You have to know what the times are, you have to know what those timestamps are, so that you can manage your care package and find out where things can go wrong. And you can improve them and then monitor the improvements. Is it scalable? Yes, it is. We had a small pilot, 850 patients. Can you do this on a much larger scale? Yes, you can, because you can automate it. Thank you.
Amazing. So I know this was about leveraging some technology, but it sounds like actually there was a lot of people research and behavior change you had to go through. Can you give us an understanding of, were you expecting that? How did you deal with that? How did you understand the context of people?
Well, we had the idea beforehand that the people management was going to be the thing.
Yeah.
We had, Ana said, more than 200 badges out there. Getting people to wear a badge, which will tell a system where you are and what you're doing, is challenging.
Yeah.
Big Brother is a concern. And people forget that their Fitbit is doing the same thing, but that's freedom of choice.
Yeah. Any thoughts from you on that, around the people?
Yeah, we always try to be as open as possible. We give a lot of information, but we also create a lot of sessions of Q&As, and we explain little by little everything that the RTLS can do and cannot do, so that people understand those limitations, that you're not always tracked. Like if you go to your team room, you're not tracked there. If you go to the toilet, you're not tracked there.
Right.
We can only see so much, you know, so we always tailor the configurations of our setups to make sure that people are comfortable and that we have quality data, of course.
That triggers me on 2 points. Let me figure out which one I should ask first. You know, this brings to mind the thought that, you know, when industries launch technologies and healthcare organizations adopt new technologies, that, you know, given the level of understanding around behavior change that you were thinking about here, for them to start to use it and to use it correctly, isn't that something maybe we should be thinking more about, not just with your pilot, but with all innovations? Do you have any thoughts on that?
Absolutely. You have to remember that healthcare is all departmentalized. Okay? And the emergency department is, in and of itself, a department with many, many departments.
Right.
And getting all the people aligned and getting them to understand that there are greater interests is a very interesting challenge. And it would change how healthcare works if a patient becomes the hospital instead of you belong to the urology department.
Right.
Exactly. And that may allow better use of assets. It may increase the efficiency of the care that we give. I think it's a very central aspect in improving the quality of care. Yeah. And certainly the efficiency.
And what about you? From a biomedical engineer point of view, how do you see that?
Yeah, I also include a lot of user research in all the projects that we do at Philips. So it's also a lot about understanding people, understanding what do they do, not what they tell us they do, but what they really do, what happens, and also tailor our projects to them so that they feel included and they also feel that they want to participate.
Yeah. And then, of course, you were dealing with a pandemic. So did the behaviors you witnessed during the pandemic, do you think those were indicative of non-pandemic situations?
Well, we were unbelievably impressed by the staff of the emergency department who continued to tag patients to do really good administration, even though COVID was rampant. We went to the board of directors to ask if we could continue the project, because basically it said we're stopping with research because everybody's focused on the pandemic. So the behavior didn't change, but the patient population did.
Yeah. Excellent. Thank you again so much. Very interesting. Anna, I know we're going to see you back shortly.